is made up of the vertebrae. Okay, there are 7 cervical, then we have 12 thoracic, 5 lumbar, 5 sacral, and 3 coccygeal or 4 coccygeal vertebrae. How it is happening? The disc is absent. They are connected to each other with the help of intervertebral discs. Okay, there is no disc between the 1 and 2. C1 and C2, there is no disc. Then there is a disc between all of them until we reach the last disc at L5, lumbar 5. There is a disc between lumbar 5 and sacrum 1, but all the sacral vertebra, they are fused to make this sacrum bone. Okay, so there is no disc between this. Plus, after S5, there is a small disc to connect the whole sacrum with the whole coccyx. And remember, again, there is no disc in the coccygeal, coccyx or coccygeal region again. So no discs at C1 and C2. Then there is no disc in all the sacrum and no disc in the coccyx. But still, sacrum and coccyx junction have a disc, and lumbar 5 and sacrum, they have a disc. Agree? Understand? Then this is actually the vertebral canal. Vertebral canal. Where is vertebral canal? Here is the body of the vertebra in front, and just back there is an opening. This is called vertebral foramen, and when we combine all the foramen, it becomes a canal, vertebral canal. This is the site of location of spinal cord, and here this is the spinal cord structure, yellow inside. Anterior spinal artery is arising from here in the skull, I told you, from the posterior inferior cerebellar, and then it will run on all the part of the spinal cord throughout the length. The 2 posterior spinal arteries, again, they arise in the skull and they reach the spinal cord on the back, and they run all through the spinal cord, posterior spinal arteries. Then we said segmental arteries. Segmental arteries from the cervical region or intercostal vessels or deep lumbar vessels, they enter through this intervertebral foramen. There is a higher degree of variation. There's not a fixed number that 5 or 6 or 7, but there is a variation. But still, when they are present, they are entering through this. They will enter through this central part, intervertebral foramen. Then they reach the spinal cord. They will divide in 2 branches, anterior and posterior. These are called radicular arteries. The radicular branches will then redistribute with small branches and anastomose with the branches running with the anterior or posterior spinal arteries. This is called reinforcement of the blood flow. Then there is a single branch usually arising from the aorta. Aorta is here in front of the spine. So aorta at the region of lower thoracic or upper lumbar, maybe L1, L2 or T12. This is the site to enter. And from where it enters, again from the intervertebral foramen. This is for the Adam-Kievisis artery, which is a branch from aorta directly to the spinal cord. Then we have another possible origin of this Adam-Kievisis or another artery, which is known as feeder artery of the spinal cord, that is rising from the posterior intercostal on the left side between 9 to 11 segments. Okay, between 9 to 11 number artery, it may give a branch as a feeder artery. So these are 4 sources of blood supply. The venous drainage, we have, this is the vertebral canal. In front of the cord and back of the cord, we have plexus of vessels going up, plexus of vessels going back, up on both the sides. Remember, there is no drainage on the lower side. All the veins of the spinal cord, they drain into the veins of the brain or veins of the dural venous sinuses of the brain. So they are highly, must have a large number of valves, I think, to display. The problem with this, they also drain the bony vertebral bodies and parts. If there is a tumor in the bony part of the vertebra, there is a higher chance of metastasis towards the brain parts. So this is one of the clinical importances. This, there is a condition called prolapse of the disc. What is disc prolapse? Intervertebral disc has 2 parts. If you see, this is the intervertebral disc. This is intervertebral disc, blue one. If you clearly see, the outer part is like hard and tough, and the inner part is soft and jelly-like. This is called nucleus pulposus. When due to trauma, damage, aging, or any other reason, the outer tough part is broken, the nucleus or jelly-like material will merge, will go out, and it can compress either the one part of the nerve, especially on the back, or both the nerves, or even the whole of the spinal cord. If suppose this is the disc, and yes, is the nucleus pulposus, and if it is compressing on the center, it is going to damage the whole cord. If it is coming out from one of the sides, it may damage one of the nerves, especially the posterior one, or here, or a bigger damage can damage the whole of the cord itself. So this condition is called prolapse, disc prolapse, or the prolapse of nucleus pulposus. What are the effects? What are the common sites? The most mobile sites of the vertebral column, they have more chances of damage. Like cervical, we have a lots of movement. Then in the thoracic, we don't have a lots of movement, except the movements of rotation. When I see on the back from here or from here, all the vertebrae in the thoracic region, they are just having a small degree of rotation, and it's supporting my head and the cervical region to shift on the back, right or left. Then we have most common chances of disc prolapse in the lumbar region. Why? Because we are bending in front or bending back. So this is again a region of damage. This is in the cervical, we are having symptoms in the hands with numbness or like other, or in the lower limbs we have symptoms like sciatica or condensation. Okay, this is the relation with, here is a, probably they are trying to show the disc prolapse. This red one is a probably they are showing to us a disc prolapse case. Okay, then we have here in this model we have, this is the front. Okay, here we have the spinal cord itself. We can appreciate the gray matter very clearly from the white matter. Okay, the anterior sulcus or the fissure and posterior only septum is also here to differentiate between front and back. Then we can see the rootlets. These are called rootlets, and one spinal nerve will arise from, like in this model you can see, yes, this is the front. Okay, so you can see from the two roots one typical spinal nerve is arising. So this is one typical spinal nerve. This is the anterior root, this is posterior root. Anterior root, posterior root. There are 31 pairs, 31 on this side, 31 on this side. Now how to differentiate? This big structure is the ganglion, posterior root ganglion, here and here both. So try to appreciate the posterior root ganglion here. Now what will happen to this nerve? This will get out at the place of intervertebral foramen. Here is intervertebral foramen. Here is intervertebral foramen. So here it is getting out, intervertebral foramen. After this, in this part, you will see, we find one nerve. Okay, one structure. After that, once it's get out of the, once it's get out of it, you will find two structures. Here is the nerve. Here is the dorsal root ganglion. Here is another dorsal root ganglion. Okay. Okay, dorsal root ganglion. From here, after this, this is the region of intervertebral foramen. After this, it will divide in two divisions: anterior ramus and posterior ramus. Okay, the anterior ramus, in cases of neck, in cases of thorax, lumbar region, it will supply the associated muscle in the line, or for example in the intercostal, it will supply the intercostal muscle, plus it will supply the skin of that intercostal space. So it is happening everywhere. Then in the region of brachial plexus, when there is, we have extension or dilatation, we should not say dilatation, we should say thickening of the cord. When we have thickening of the cord in the cervical region, it's there to give you more area for the origin of brachial plexus, the bodies, the cell bodies. The anterior division of 4, 5, 6, 7 and 8 T1 or 5, 6, 7, 8 T1 will give you the origin of brachial plexus, and this is going to supply the whole upper limb and the flexor and extensor compartment. Similarly, anterior divisions here, anterior divisions only. The posterior division will go back and supply as per routine. Here in the lumbar region, the anterior division will make the lumbar plexus, the posterior division will make the sacral plexus, plus there is a branches from the posterior, and these two plexuses will supply the muscles of the lower limb, including the gluteal region. Okay, this is about the spinal nerve. Each spinal nerve has a connection with this structure, sympathetic chain. What is sympathetic chain? Sympathetic chain is the chain which is composed of sympathetic ganglia. Sympathetic chain is running in front, like here, on both the sides, like here, like here. And how it will finish, terminate here in the end, in the lumbar region, there is one big ganglion in the center. This is called ganglion impar, IMPAR. So this chain will come and will finish here. So each spinal nerve has two connections with the sympathetic ganglion. So now these two fibers will have, up till here we have sensory and motor separately arranged. Okay, after that there is a combination or a mixture of sensory and motor. And now after this connection with the sympathetic chain, now both these have sensory fibers, both these have motor fibers, and both these have sympathetic fibers. What the sympathetic fibers will do? Anyone? Yes, surely they are postganglion. But the sympathetic fibers will do in a spinal nerve. They are going to supply the muscles and vessels. So sympathetic system of the vessels, yes, vasomotor, vasoconstrictions is going to happen by this way. This is another thing. Then what are the structures available here? This, can you appreciate this yellow of with some veins like structure? This is dura mater. This yellow is dura mater of the spinal cord. And what are these veins? I told you there is epidural space. I told you there is epidural small fat. So this yellow is probably epidural fat or the dura mater. Then there are three group of vessels in behind and three group of veins in front. These are venous plexus in the epidural space. This is dura mater. If you go inside dura mater, this blue margin is arachnoid matter. Okay? Inside the dark one is pia mater. And this pia mater is going to make you ligamentum denticulatum and other support and filum terminal. Anything? I don't think it's left something here. Okay. This is our original spinal cord. This is the original spinal cord. What we are seeing is the spinal nerves. Okay. They are 31, but some of they are damaged, so they may not be 31 in this specimen, no problem. When they get exit, they should leave dura mater, arachnoid mater and pia mater. So a small sheath. So this is actually the dura mater. These two spread areas is actually the dura mater. It was like this. Okay, it is cut to show you the real cord. So this is the spinal cord. Here is the start at the level of medulla oblongata, and in a fresh sample here we can even see white and gray matters together. They can be differentiated. Then we have, you may find some opening or passing through of the spinal nerve because it has to cross the dura mater. This is dura mater. This external, this layer is dura. It was like this actually. This is the start point. At the start point, after that we have a thickening. So this is the cervical region. Then again we have a thickening. This is the lumbar region. Okay. Then the most central structure. Here is the conus medullaris. This is the conus medullaris. Can you appreciate this conus? Okay. At the conus medullaris we have this. After that we have this thin structure, filum terminal. This is filum terminal and this is conus medullaris. And surrounding these nerves, these are called cauda equina. This is a specific level of L1 or L3 in children and adults. We have difference. Then this filum terminal will cross both dura mater and arachnoid mater and pierce them, and then it will go to the coccyx to be attached here. So only a thin filament will come and attach to the posterior coccyx, probably coccyx 2 or coccyx 1. Coccyx 1 is that. L1, coccyx 1. Remember two things like this, and in between this dura and arachnoid will finish approximately at S2. So after this and before this, we have ample space for lumbar puncture to be done. Okay, so this is the after L2 3, between the space between L2 3 is probably the ideal space for lumbar puncture. I hope we finish here. Anything left?